Hi, I'm Elisa Nussbaum, a registered dietitian affiliated with Yale New Haven Hospital in Connecticut. I'm doing this on behalf of the International Medical Crisis Response Alliance, and I hope that you find it helpful. This first slide is just a brief overview of what I hope to cover today in this presentation. I'm going to walk you through the most common nutrition concerns that cover the refugee population, while keeping in mind that the available food and nutrition resources may vary dramatically from location to location. Because of that, it's essential that you know your patient population and the most frequent nutrition-related medical concerns that face your specific group. We're going to look at identifying and treating malnourishment and stunted growth, as well as refeeding syndrome, common nutrient deficiencies and their resulting disease states, and nutrient needs for recovery from trauma and wound repair. Malnutrition can be acute or chronic. The three classifications of acute malnutrition are marasmus, kwashiorkor, and a combination of both. I'm going to go over the signs and symptoms briefly so that we can move to treatment. Marasmus is the most common as the body breaks down fat and muscle to be used for energy in the absence of caloric intake. Signs and symptoms include wasting, decreased liver function, hypoglycemia, hypothermia, heart failure, and low weight to height Z-scores. Kwashiorkor includes bloating with bilateral pitting, most often beginning in the feet as mild edema and moving to a severe ranking as more of the extremities become affected. Additionally, loss of appetite, apathy, and dermatosis join the previously listed symptoms. It's important to note that with kwashiorkor, the patient's weight may be falsely elevated because of the massive amounts of fluid retention. Here's a chart that can help you differentiate between a well-nourished patient and one with mild to moderate or severe malnutrition in your physical exam. Even the most non-invasive examiner can easily see temporal wasting or wasting in the web of the hands in a malnourished patient. When introducing nutrition to a previously starved patient, there are a few potentially harmful consequences, particularly for patients on nutrition support. Carbohydrate introduction results in insulin secretion, which in turn promotes glucose uptake, along with phosphorus and other electrolytes into the cell. This intracellular shift, alongside the electrolyte pool that is depleted, can lead to dangerously low levels of serum phosphorus, potassium, and magnesium, resulting in potentially serious respiratory, cardiac, and neurological complications. Advance the patient's diet slowly, including fluids and sodium, to avoid potentially serious consequences. For patients on nutrition support, my institution guidelines have initial carbohydrate intake offered at 150 to 200 grams per day or 2 milligrams per kilogram per minute, with up to 1.5 grams of protein per kilogram of ideal body weight, or obviously as clinically indicated. Chronic malnutrition or stunted growth is a long-term effect of inadequate nutrition, beginning with a lack of proper prenatal care along with frequent infections resulting from poor nutrition. At a certain age, this loss of growth becomes permanent. According to UNICEF, the most common micronutrient deficiencies worldwide include vitamin A, iron, and iodine. Vitamin A deficiency causes various diseases of the eye, impairs the immune system, and can increase the severity of measles and diarrheal diseases. Iron deficiencies are most common in pregnant women, preschool and school-age children, and the older population. In addition to weakness, lethargy, and headaches, excessive paleness of the eyelids, palms, and tongue can be symptoms. With iodine deficiencies, swelling of the thyroid gland or goiter can be seen and also can result in severely stunted physical and mental capabilities. Nutrition needs can vary significantly from patient to patient, and the presence of multiple acute events and disease states will factor in as well. Clinical judgment should always be used when estimating both calorie and protein requirements. Typically, my institution prescribes 25 calories and 1.5 grams of protein for recovery from such illnesses as mild infections, including things like UTIs, cellulitis or pneumonia, uncomplicated surgical procedures, or a mild wound. Moderate recovery, such as that from a stage 3 pressure ulcer, a bone break, pancreatitis, intracerebral hemorrhages, or sepsis, require 30 grams per kilogram body weight per day and 1.5 grams of protein per kilogram. The most severe medical issues have nutrition needs estimated at 35 calories per kilogram and 1.7 to 2.0 grams of protein per kilogram, and would be used for those with stage 4 and above pressure ulcers, patients in a catabolic state, severe sepsis or severe shock, or septic shock, or those with traumatic brain injuries. Nutritional needs can be adjusted downward as the patient recovers. Typical recovery is 21 to 30 days, about 3 to 4 weeks, although this timeline can vary. Patients with spinal cord injuries or traumatic brain injuries can require a longer recovery. Nutrition can play a large role in wound healing as well as wound prevention. While there are only limited large-scale studies on the topic, here are a list of the roles certain nutrients are believed to play in wound care. Individuals should be provided with 100% RDA of vitamins and minerals, whether through the use of fortified supplements or a standard multivitamin with minerals included. Adequate caloric and carbohydrate intake supports collagen synthesis, growth of new blood vessels, positive nitrogen balances, and anabolism. Caution must be taken not to overfeed a patient, as this can impede wound healing as a consequence of increased carbon dioxide production and hyperglycemia. Carbohydrate intake at 50 to 60% of total calories currently is the recommended amount, and that will spare protein for healing functions. Protein plays a role in blood vessel and fibroblast formation as well as collagen synthesis. Inadequate protein intake can lead to increased edema and poor healing. Research to date demonstrates that feeding more than 2 grams per kilogram ideal body weight, except in instances of severely catabolic patients, will not improve wound healing and may increase risk of other complications, such as overtaxing renal or hepatic functions. Adequate fluid is essential, as dehydration can lead to decreased blood flow and decreased turgor, which will delay wound healing. Standard recommendations are approximately 30 milliliters per kilogram body weight, or 1 milliliter per kilocalorie per day, with a minimum of 1,500 milliliters of fluid per day. Keep in mind that those with draining wounds or fevers may have additional fluid needs, so you'll also need to consider other clinical conditions such as CHF or gross fluid overload. Arginine and glutamine are essential amino acids, and these are thought to play a large role in wound healing as well. Arginine acts as an immunomodulator and may enhance inflammatory mediators involved in tissue growth. Arginine plays a role in nitric oxide release, stimulating wound contraction and activating macrophages and the generation of blood vessels and collagen. Glutamine assists in tissue regeneration process. The current standard does not recommend supplementing glutamine to individuals with wounds. Vitamins A and D, cofactors in collagen synthesis, are recommended in weight-appropriate amounts, although supplementation of vitamin A, D, and zinc is encouraged in patients who are shown to be deficient. We've covered treating acute and chronic malnutrition, micronutrient deficiencies, as well as nutrition care for trauma and wound recovery. But what are we missing? Some important nutrition topics to be covered in a later module are nutrition concerns specific to pregnant women and infants, including breastfeeding. Additionally, some long-term populations may be susceptible to emerging diseases such as type 2 diabetes mellitus or heart disease because of newly sedentary lifestyles and differing nutrient makeup of their diets. I hope you found this information valuable. Thank you.